So these are our learning objectives. Inshallah, we will try to understand the clinical uses, we will learn how to calculate the dose, and what about the complications. Okay, so local anesthesia basically can be used as topical anesthesia and local infiltration. Topical anesthesia means that we are using this anesthetic over mucous membrane or skin. Okay, so that part of the mucous membrane or skin will be anesthetized. So for example, intranasal spray. Okay, so intranasal spray that can be used prior to any manipulation in the nose, throat, or upper airway. Okay, and there's ocular anesthetic drops. These are not ideal for the surgery, but basically these can be used for assessing initial assessment of minor injuries and for removal of the foreign bodies. Okay, and xylocaine spray, that can be used in the throat prior to the endoscopy, for example. Okay, and amla cream. Amla means basically eutectic mixture of local anesthetic. Okay, this is the mixture of lidocaine and the prilocaine. Okay, so what do we mean by eutectic? Eutectic means that if we are combining two different chemicals and they have different melting point, when these will be combined, then both of these now after combination will have a similar melting point. This is the definition of the eutectic. Okay, so this is the eutectic mixture of local anesthetic, and that is used for example prior to inserting any cannula or taking blood sample from children. Okay, but the only thing is that has to be used at least 1 hour prior to any procedure, because that takes a little bit time to be effective. Okay, and for example we can also use local anesthetic over the gingiva whenever there is some inflammation or minor injury, that can be used for the pain relief. Okay, infiltration means that we have to infiltrate the local anesthetic into the tissues. Okay, for example, if we have to take out a plantar corn, so we can infiltrate the local anesthetic around this, so that whenever we will start surgery, patient won't feel any pain. Okay, we can also use these local anesthetic for digital nerve block. For example, if some patient has paronychia. Okay, paronychia means there is infection around the nail bed. Okay, so if we have to drain this abscess, if I will put in infiltration here, then it will be severely painful because already it's inflamed. Okay, if I will infiltrate local anesthetic here, it will be severely painful. Other thing is that it won't work because of the difference in the pH as well. So that's why digital nerve block is very much suitable for such type of surgery. Okay, for example, if we have to remove the nail, this is the traumatized nail, and if I have to remove it, I can use the digital nerve block. So you can see here that the digital nerves, how these are supplied, that for each digit there are 2 digital nerves. Okay, that means if I have to anesthetized a single finger, I have to infiltrate the local anesthetic on either side of the finger. Okay, and in this actually we can use 1 to 3 cc of local anesthetic, 1% or 2%. Okay, but remember that we have to be very cautious while using adrenaline. Okay, we will discuss later on what are the problems with the adrenaline if we mix it with the local anesthetic. Okay, let's see. Okay, Now, what about the dose calculation? Remember, this is very important to learn how to calculate the dose for the local anesthetic, because that is a very favorite question in the exam, and moreover, that is very commonly used in the practical life as well, because as soon as you will start your internship, inshallah, there will be several cases of local anesthesia use. So if you know how to calculate the dose, so at least you can avoid the complications. Okay, so first of all, what do we mean by the dose calculation? Actually, we are calculating the maximum dose limit. So what does that mean? That means that if I am calculating the dose for a particular patient, that means this much dose is allowed for that patient, and if I will cross that limit, there will be high chances of complication. But that does not mean that I have to use that much dose at any cost. For example, the dose calculation for antibiotic for children, it is different. That means whatever I have calculated, I have to give that amount to that kid. But here, that means, for example, if I am removing lipoma, okay, so if my calculated maximum limit is 10 cc, okay, but when I am just doing surgery, I have noticed that only by giving 5 cc, patient is comfortable, there is no pain sensation. So that does not mean that I have to give 10 cc. If the patient is comfortable, I can continue my surgery with 5 cc of the local anesthetic. Are you getting my point? That means this is the maximum dose limit. That does not mean that I have to give that much amount to the patient. Okay. Okay, and we have to discuss about the plain versus with adrenaline, because the dose is different. Okay, and why the dose is different, we have to discuss that. Here we have taken example of xylocaine, because that is the most commonly used local anesthetic. Remember, xylocaine means lidocaine. Okay, so lidocaine and other local anesthetic are available as plain injections and as well as with the adrenaline. So local anesthetic dose for plain injection, it is much lower than that with the adrenaline. If we are using local anesthetic with the adrenaline, then maximum safe limit dose is much higher. Okay, why it is so? Because you know that adrenaline causes vasoconstriction. So if there is vasoconstriction, so what happens? Actually, the absorption of the local anesthetic from the site of infiltration is slowed down. So if that is slowed down, that means the chances of side effects are much lower. That's why the safety limit is much higher with the local anesthetic if that is available with adrenaline. Okay. So here we will take the example of xylocaine plain 2% for the dose calculation. Okay, as we know that the dose is 3 mg per kg. I have taken this dose limit from your book, because if we just check different books, there is a range given 3 to 5 mg per kg. But why we have taken this dose? Because that is mentioned in Bailey and Love. And remember, whatever calculation will be in your exam, that will be from your book Bailey and Love. So that's why we are taking all the reference values from your book Bailey and Love. Okay, so the dose for the xylocaine plain is 3 mg per kg. So now take an example. If your patient is 60 kg, okay, so what does that mean? That means that for this patient you have to multiply it with 3. So 3 multiplied with the 60, so that will come up with the 120 mg. But the problem is that here it is in mg. while you must know in the ml, because that is a liquid and you are injecting it as a liquid, so you must know how many mls you have to give. Okay, so if you know the percentage of local anesthetic, then it is much easier. That's why in your exam question always we will give the weight of the patient and the percentage of local anesthetic. You have to focus on that, because for example, if we are using 2% xylocaine, that means in 1 ml of this there will be 20 mg. In 1 ml 20 mg of xylocaine will be there. So that means if I have to just convert mgs into mls, I have to divide mg by the ml, by this 20. Okay, so we calculated 120 mg. Okay, so this is 120 divided by the 20, because we are using 2%. So in 2% we know that there are 20 mg, so we have to divide it. For example, if I am using 1% xylocaine, so 1% xylocaine means 10 mg per ml. Okay, so that means in that case I have to divide this 120 by 10. Okay, for example, if I am using 0.5% xylocaine, so that means in that case I will be dividing 120 by 5. Okay, that is a simple maths. So what is the result? The result is 6 ml. Okay, so that means for this patient of 60 kg weight, I can give 6 ml of plain xylocaine 2%. Okay, but if I'm getting results with, for example, 4 or 5 ml, so no need to give 6 ml. Okay, this is just the maximum dose limit, so that I can avoid the complications. Okay, now what are the side effects? Okay, let's see side effects. As you may be remembering that xylocaine or the lidocaine is basically an anticonvulsant and as well as antiarrhythmic medication. So but you can see here in this graph that in very low doses it has this therapeutic effect, anticonvulsant and antiarrhythmic. But if the dose becomes higher and higher and higher, there are complications. And from here in this you can notice that the complication or the side effects of the CNS are at much lower dose than that for the cardiovascular system. Okay, and how we get these side effects? Usually this is by the intravascular injection. If I'm just infiltrating the local anesthetic and I'm not careful enough and I'm not aspirating before injecting, so what may happen? This local anesthetic may go into any vessel, and if it will go into a vessel, so directly it will be in the systemic circulation, and then there will be chances of side effects. So we have to be careful. And in this picture you can see clearly that initially at the lower doses you have the side effects of perioral numbness and tinnitus, and as the dose is increasing and increasing, then you may your patient may have seizure and the coma as well. So you have to be careful, and that's why usually we advise that you have to continue to talk to the patient, and well before starting the surgery you have to counsel the patient. You have to inform the patient that if patient feels any issue or especially perioral numbness, then he or she must inform you, because in these stages it is much easier to control the side effects. But if patient goes into this cycle, so naturally it is really very difficult, and you have to call anesthetic for the help, because then this patient may need barbiturates or even endotracheal intubation. Now the pain management. So inshallah now we will learn the different methods of providing pain relief. Okay, that is quite famous analgesic ladder, and you already know that whenever there is pain, so we have to start from very from non-steroidal analgesics, and then we have to go up. But now there are some changes, and now it is said that actually that is only for the chronic pain. Okay, in the chronic pain you can start from the non-opioid analgesics, and then weak opioids and strong opioids, and then neurolytic therapies. Okay, but if the pain is acute, severe, so naturally in that case you don't start with the NSAIDs. अब अगर किसी के वो जो है सिर्फ फ्रैक्चर हुआ है और वो ट्रॉमा का पेशेंट है तो सिवियर पेन में है, so naturally you are not offering paracetamol. So in that case you have to start from the upside of the ladder and then go down. Okay, so first we will talk about the chronic non-malignant pain. Basically, what is the difference between the non-malignant and the malignant pain? Because you know that in benign conditions you are giving pain relief so that there is no damage to the nerve plexuses or the nerves. Okay, while in malignant pain, because usually there is severe pain at the last stages of the cancers, in that case you can ablate the nerves or the nerve plexus. That is the main difference. Okay. So chronic pain control in benign disease, naturally you start with that of the medication, as we have talked about earlier, and simple NSAIDs and non-opioid medication and opioid medication as well. As you can see, fentanyl is actually an opioid. This is just like to that of the morphine, but this is much more potent, even 50 to 100% more potent than that of the morphine. Okay, so and that is also available as the transdermal patch that may work for even 72 hours. Okay, and that is quite a common practice to have the local anesthetic and steroid. For example, if there is rotator cuff tear or in frozen shoulder. Okay, and that is common practice that alleviates the pain instantaneously, and that pain relief is for a longer period of time. Now the nerve stimulation procedure, that is very common. You know this by the name of TENS, transcutaneous electrical nerve stimulation. Okay, and actually there are two theories that by this method there is release of endorphins. Okay, endorphins are just like internal morphines. Okay, so as the morphine is an analgesic, endorphins are also analgesic. So by this therapy there is release of endorphin. The other theory is the gating theory. Gating theory says that if there is non-pain input, that actually blocks the pain input. That is the theory behind that, and that can be this method can be used for pain, variety of pain. For example, the neck pain, the shoulder pain, okay, back pain. Okay, this is the TENS unit. Okay, and spinal cord stimulation, that also works on the principles of gating theory and endorphin theory. Okay, and this is used for chronic severe pain, refractory pain of the neck and the back. In this, actually you can see here, these are the stimulators. These are put within the spinal canal, and there is a battery along with that releases some impulses, and because of these impulses there is gating. That means non-pain input closes the pain input. Now, what about the pain control in malignant disease? In malignant, as we have talked about earlier, that we have to follow the analgesic ladder. In that case, remember that if we are using one type of opioid and that's not working, we can change the opioid, because sometimes one type of opioid is not working, but the other type of opioid may be working, and we may also have different combinations of medications. Okay, before we choose a procedure that is intense enough. Okay, neuroablative techniques, as we have talked about earlier, that we can use neuroablative techniques in malignant pain, because in that case that will destroy the nerve, so usually that is avoided in chronic non malignant pain. Okay, celiac plexus block, as you know that celiac plexus is behind the stomach, and there are several plexuses arising from this major plexus. For example, the gastric plexus, splenic plexus, and the pancreatic plexus, and the hepatic plexus, and the renal plexus. So many plexuses are arising from this. So if you are blocking this, so you can stop the pain arising from these areas. And specifically this is used for pancreatic cancer and even in the gastric cancer, and sometimes this can be used for severe refractory chronic pancreatitis as well. Achha, if you are using a phenol or alcohol, so basically that destroys the nerves. As you can see here, I have just put this injection here. This is the neuroablative injection. Okay. Okay, the endoscopic ultrasound guided celiac plexus neurolysis. Neurolysis means we are using phenol or alcohol into the nerve plexus so that there is a destruction of the nerve plexus. Okay, actually there are various ways we can do this, that can be done under ultrasound guidance, as you can see here. This is the endoscopic ultrasound, and even under the CT guidance or under fluoroscopic guidance that can be performed. Okay. Now the superior hypogastric plexus block, because actually if you know that superior hypogastric plexus that supplies to the lower abdomen and the pelvis, so naturally this can be used for pain arising from the lower abdominal viscera and the pelvic viscera, for example the genitourinary cancers and the lower abdominal cancers. Okay, for example the colorectal cancers. Okay, and this is the method how it can be given. Patient is in the prone position and you can see the needle here, and this is the vertebral column, and in the paravertebral space he will be going, and that can be done just like other celiac access celiac plexus block we talked about, that can be done under CT guidance or fluoroscopic guidance or even the ultrasound guidance. So these are the references